For sure, thank you. So yes, as he said, I'm Jessica and I'll be presenting today. I have an educational background in medical sciences and I've been with Nanostics for about a year in the role as a business development associate. Um, so yeah, I'll hand it over to Sean to give a quick overview of himself and his role.
Thanks. Sean Secord. I'm the VP of Clinical Engagement with Nanostics. I have about 30 years of history as a clinician and a health leader all across Canada. But I got involved with this as a volunteer, actually, with Ride for Dad. I chaired a chapter of Ride for Dad raising money for prostate cancer in the North. And we ended up funding the research that led to the development of this test because back in 2017, we saw the potential of this really benefiting men in the North where there are no urologists. So yeah, that was my beginning to this, and then I followed my passion and started working for the company a couple of years ago.
So, all right. So technological advances in prostate cancer screening is the title of today's presentation. And what I hope to share with you all through this presentation is the current state of prostate cancer screening, some pros and cons of these practices, and some innovation in this field that us at Nanostics are involved in. So our story begins with this man, Frank Sajonki. He was an Alberta businessman who was diagnosed with prostate cancer in the 90s. And in order to get treatment, he had to commute from Edmonton to Vancouver. And during this process, he realized that there was really no prostate cancer research going on in the province of Alberta, and he set out to change that. So he got a group of people together and they fundraised a large amount of money and were able to set up a foundation. His first act was to hire a researcher, Dr. John Lewis, who is our CEO. And he hired Dr. Lewis to create a prostate cancer research group. And here at the University of Alberta in Edmonton is the John D. Lewis Research Group. And one of the group's major goals over the years has been to develop an improved prostate cancer screening tool. So a lot of time and effort has gone into this and a lot of developments were made. However, since this research group was part of an educational institution, they could not commercialize their findings. So in order to translate their research into a clinically available product for patients, Nanostics was formed in 2017. So Nanostics is a precision health company with a mission to enable better diagnosis by providing clarity to people about their health. And the tool, as mentioned before we presented, the tool that Nanostics has developed and what I will be getting into later in the presentation is called ClarityDX Prostate. And the term clarity is pulled from these themes on the right here that we see as pillars for the work that we do. So collaboration, learning, accuracy, reliability, innovation, and quality come together to form clarity. So why prostate cancer? And I'm sure this is some information that many of you are aware of, but it is one of the most prevalent cancers out there, as well as the second leading cause of cancer-related death in men. For Canada alone, there will be almost 28,000 new diagnoses this year, as well as 5,000 deaths from prostate cancer this year alone. What's extremely important for prostate cancer is early detection. As you can see here, if it's caught while it's still localized within the prostate, the survival rate is greater than 99%. However, if it's caught when it's already reached distant tissues, that survival rate drops to just over 30%. And the primary screen tool historically for prostate cancer has been PSA screening. So anytime the prostate is irritated, PSA or prostate-specific antigen is released into the blood. And one of these causes of irritation can be prostate cancer. So as you can see here in the mid-90s, when PSA screening became a more broadly used tool in Canada, there was a pretty immediate drop in mortality from prostate cancer, about 3 to 4% yearly once it was introduced. Here's another study that's looking at the effectiveness of screening tests. So this study took a number of different cancer type screenings. PSA is there in the thick black box. And essentially the study looked at lifetime gain versus lifetime loss. The lifetime gain, of course, is catching cancer earlier. Lifetime loss is anything from anxiety and stress of screening procedures, screening interventions, exposure to radiation, etc. Now, what you can see specifically with the PSA that it has a net lifetime gained. So essentially it's saying that PSA screening is effective. So if prostate cancer screening with PSA testing reduces prostate cancer related mortality, why has it not been more strongly recommended? Following PSA screening, when you have elevated levels of PSA, the next step for a formal diagnosis is traditionally a biopsy. More recently, MRI has become an option as well. However, these can be expensive, risky, invasive procedures. Of course, MRI, expensive, long wait times. Biopsy is a very uncomfortable, invasive procedure. It's usually transrectal, so you're putting 12 needles through a bacteria-rich environment in the rectum, and there's a number of associated risks, bleeding, infection, urinary issues, etc. And with these formal diagnosis techniques, the results most often show that there is no prostate cancer or indolent prostate cancer, so not clinically significant. Now, as I said before, PSA is elevated when the prostate is irritated. However, only about 20% of the time that you have PSA elevation is due to prostate cancer. The other 80% is due to benign reasons such as exercise, sexual activity, or a whole number of benign reasonings. So the concerns with PSA screening is that you have a lack of specificity, as I just touched on. So there's a high burden of investigation, or a lot of men who are going through these risky procedures such as biopsies unnecessarily. The other major concern is that there's an overdiagnosis of clinically indolent prostate cancer, which leads to overtreatment. And because of these concerns, in 2012, the U.S. Preventative Services Task Force actually came out with screening recommendations for prostate cancer that were against PSA screening. Followed quickly by Canadian Task Force, which put out the same recommendations in 2014. However, in 2018, the U.S. Task Force realized that this was an overcorrection, and they updated that in 2018, and it's currently under review before they put out their next set of recommendations. In Canada, they have said for a while that they've planned to do updates for next year in 2026. However, within the last couple of months, this task force has been put on pause, so there's not much clarity there from the Canadian side of things. And this study shows a big reason why the U.S. reversed course, the U.S. task force reversed course. What you see in the 2010s after they recommended against screening is a drop in early diagnosis or local diagnosis, which again has greater than 99% survival rate, and a noticeable increase in late stage diagnosis, which has a much shorter or a much lower survival rate. And this is a little bit of a complicated slide, but essentially this is what their review process looks like currently. And each number in this diagram represents a path that the task force is investigating. If you look at these highlighted paths, number 3 and 4 right here beside my mouse, those are for asymptomatic men where they're looking to determine the accuracy and the effects of adjunctive testing strategies such as pre-biopsy prostate cancer risk scores. And by adjunctive testing strategies, we mean additional tools that could be used to reduce the issues with PSA testing in the screening process. For comparison, the CUA, which is the Canadian Urological Association, they came out with their own guidelines in 2022 and said PSA screening should not be avoided. However, they did note, similar to the US Task Force review, the potential for adjunctive testing strategies to be used to combat these concerns with traditional PSA screening. And this is similar to the slide I just showed you. This is a more visual representation of what the CUA is recommending. So on the bottom there, you can see those with a PSA above 3, aka elevated PSA. Instead of going straight to a biopsy, you can go, in between that, you go to adjunctive strategies, potentially reducing the amount who go forward for a biopsy. So what are the goals of an ideal prostate cancer screening approach? Well, first, number one would be preserve the mortality benefits of prostate cancer screening and catch prostate cancer early. Number two would be to reduce overdiagnosis and overtreatment by not exposing low-risk cases to invasive diagnostic procedures. And that's where our tool, ClarityDX Prostate, comes into play. So ClarityDX Prostate is a machine learning, non-invasive screening tool that can be used as an adjunctive strategy. So it's 3 to 4 times more accurate than PSA alone. It's been validated using real-world evidence. It can reduce costs to the healthcare system and to individuals, and it helps prioritize and reduce wait times for MRIs and biopsies. On the left here, you can see a research article of our tool that was published 2 Junes ago now, so June 2023, in Nature Digital Medicine. And this is the validation study I just touched on. So it was done across the world, almost 3,500 patients. The sites that participated were the University of Alberta and the University of Calgary. As well in the States, we had Johns Hopkins as well as UCLA, and then Tamir University in Prague, Czech Republic. So how does ClarityDX Prostate work? So as I said, it's a machine learning algorithm, and it incorporates biomarkers as well as clinical features into this algorithm. So the 2 biomarkers that we use are total PSA and free PSA. So the PSA in your blood, some is free floating, some is protein bound, and the percent of free PSA can give you that free to protein bound ratio that helps give you an idea of the association that PSA has to prostate cancer. And both of these biomarkers are received from the patient through just a simple blood test. The clinical features there's 2 that are required. So first, age of the individual, and if they've had any previous negative biopsies. There are a few optional and advanced clinical features that can be added, but they don't have to be. So if the individual has had a recent digital rectal exam, those findings can be added, as well as prostate volume and PIRAD score if that data is available. So all that data is inputted into the machine learning algorithm, and a risk score results in a risk score being given to the individual. So it's either a high risk or a low risk. Low risk, it is recommended that they take an active surveillance or a watchful waiting approach where they don't go for a biopsy, but they continue to get regular PSA screening. High risk, it is recommended for that individual to go ahead and continue to get a further biopsy. So this is a very kind of data-heavy screen. However, what it's showing is the accuracy of ClarityDX compared to PSA alone. So this chart here, you can see specificity is along the bottom, sensitivity is along the top. And a perfect screening tool would have an area under the curve on this graph of 1. So it would be right in this top left corner. However, the black line here, you can see that is PSA alone. So the area under the curve, which indicates accuracy, is about 0.63. The baseline ClarityDX Prostate, which includes age and any previous negative biopsies, is the purple line, and that's 0.8. As you add potentially a DRE or an MRI or both, you increase the area under the curve and the accuracy even more. And once you get to an area under the curve of 0.87, that's equivalent to the accuracy of a biopsy without any invasive procedures going on. So looking at integrating the ClarityDX into the guidelines. So this, I showed you a few slides earlier about the Canadian Urological Association guidelines. This is where ClarityDX Prostate could come in considering adjunctive testing strategies. So again, ClarityDX Prostate would result in high-risk individuals who are recommended to go get a biopsy and low-risk individuals who are recommended to continue monitoring with PSA screening. And the potential for ClarityDX Prostate is to avoid 32 to 47% of unnecessary biopsies, as well as prioritize high-risk cases. So those who do need a biopsy and or an MRI, the wait times will be shorter because those with low risk will no longer be in those wait lines. And this is an example of what the test results look like. So this would be sent to the ordering physician after the test is run and the results come through. So these are 4 different patients, 1, 2, 3, and 4. And you can see that top left here in patient number 1, they have a low risk score. So they would be recommended against continuing with a biopsy. However, patients 2, 3, and 4 have a high risk score, and they would be recommended to continue on with a biopsy for diagnosis. Now, what's interesting is all 4 of these individuals have the exact same PSA level. They have 3.5 PSA. However, you can see they all have different individual risk scores. And this slide currently shows where ClarityDX is currently available. So Quebec, Ontario, Manitoba, Saskatchewan, Alberta, BC, and the Yukon is where our test can be ordered. In Ontario, specifically similar to Saskatchewan and BC, we have a partnership with Life Labs. So they collect the blood that is sent to our lab in Edmonton, Alberta, and then our test is run there, and then the results are sent back to the ordering physician. Internationally, we have a partnership with a lab in Florida, and so very soon it will become available in the US, as well as we have a partnership with a lab in the Middle East. So both of those will be available in those regions shortly. So with everything I've gone over in the presentation, in order for ClarityDX Prostate's benefits to be seen, it must be adopted into the healthcare system. And there are a few main hurdles associated with this. So awareness is a very big hurdle for us. Why Sean and I are here presenting to you today is this awareness piece. In order to use the test, people need to know about it. And a lot of what Sean and I do is engaging with patients, physicians, groups like yours to increase awareness and knowledge. Getting integrated into guidelines is a pretty slow and steady process. In Canada alone, there are 15 different healthcare systems between the provinces and territories, veterans, Indigenous, RCMP systems. So again, Sean and I have spent a lot of time engaging with these groups, making them aware of ClarityDX Prostate. As well in the US, Sean has spent quite a bit of time in contact with those groups in the US that will help us integrate into their guidelines in the future. And as mentioned earlier, our test is available currently in 6 provinces and the Yukon. However, it is a private pay test right now. A couple months ago, we began a clinical utility study here in Alberta at the request of Alberta Health to demonstrate ClarityDX's benefits to the care pathway as well as healthcare cost savings. And the results of these studies, which we hope to get within the year of starting the study, will lead to coverage from Alberta Health in Alberta, and we anticipate this will get the ball rolling on other provincial health authorities covering the test as well. So thank you very much for listening. I've added Sean in my emails there if anyone wants to contact us further. As I said, we have time now to also have a bit of a Q&A. I don't know if there's any questions in the chat yet. I don't have the QR requisition form in this presentation. What I can do, Al, is send you a link to that if you wanted to share it with everyone. It's also, on the bottom left of this slide here, you go to our website, nanosticsdx.com, and
Okay.
on the header of the home page is an order now button, and that will take you to the requisition site. You will still have to choose your province, and then you can get your requisition forms specific to that. Yeah. So the cost right now is, the test itself is $300. However, as I said, we have the shipping and ordering agreement with Life Labs in Ontario. So that shipment to get the blood to Ontario is another $200. So looking at, for a patient in Ontario, is currently $500.
But as you said, Alberta has, they're having you do a study, and the indications are that it should be covered in Alberta in the fullness of time. Have you started anything in Ontario?
No, so ideally we will not have to do what we're doing right now is called a clinical utility study. That's showing the benefits for the care pathway and cost savings for the province. The idea is that we're not going to have to do that study for every province or every jurisdiction. And Sean can speak to this a bit more if you wanted to.
Yeah, the clinical utility study was a requirement of Alberta Health Services, but we have partnered again through money raised by Ride for Dad. There's a clinic in Manitoba called the Men's Health Clinic that applied for funding through Ride for Dad. They're using that funding to become a clinical site in the study. So that will help involve Manitoba patients. And we are also looking to involve a site in Toronto. Theoretically, like when the results, we'll get the most patients in Alberta because that's where it was formed. That's where we have a lot of people who are aware. And Alberta Health Services has promised to pay for this once the study results are quite clear. The BC government has also promised to pay for it once they see the Alberta results. So theoretically, we shouldn't have to run the same study, like Jesse was saying, in every province. We are going to recruit in Toronto and Manitoba. Again, the argument is much more clear when you could say, look, we have Ontario patients. We have proven that this is effective, efficient, has better health outcomes, and saves a whack of money, not only just for individuals, but for the health system. You're avoiding biopsies, you're avoiding wait times, anxiety, lost work, lost wages, productivity. All of these things are quite evident by having a rapid risk score to say, oh, your PSA was elevated for a reason that's probably benign. You don't need a biopsy. You don't need to see urology. From you are a high-risk patient, you go to the front of the line, we treat you early and it's effective. So that's the idea of the study, and there will be some Toronto patients involved.
Okay, thank you. Doug has his hand up.
Yes. I just a question about the blood work. So you said if our blood is taken in Ontario at Life Labs, who we have here in Morrisburg, and shipped out to Alberta, I thought like the blood had to be shaken and tested in a shorter period of time than that. Like, how does that work? Like when we do a test here, we were told it has to be done basically the same day, or the blood has to be looked at within a certain amount of time.
That's part of the cost, Doug. Life Labs takes the blood, they're going to centrifuge it, so they're going to spin out the serum and get rid of the red blood cells. Then they're going to take some of that serum off as what's called an aliquot, and then they're going to put that on dry ice and then ship it to Edmonton. So as you can see, all of these labor-intensive parts is why they charge $200 for that component. So on dry ice, that blood is stable for a long time. You are correct. You want to measure it soon, but dry ice extends that time.
Okay.
And ideally, ideally, if Life Labs actually ran the total and free PSA and just sent us the information, then it would be much faster and much cheaper, which is an ideal future state.
Okay.
Because this is new and we're sort of negotiating relationships and contracts, right now the contract is we'll send you the blood, but in the future, it should just be sending information instead of blood, so it'll be cheaper and faster.
Yeah, sound okay. Thank you.
I got a question. You've interacted so far with the Canadian Urological Association, probably quite a bit. How would you gauge whether or not they're on board with your approach?
So the CUA has a conference every summer. This summer, it's actually taking place in a couple of weeks in Ottawa. We
Yeah, we know.
have presented at the last 3 conferences, but at this conference coming up in Ottawa, we're actually doing what's called an advisory board, which is involving about a dozen urologists in a focus group. So just to come to that very conclusion, to get their input, because it's a long process for physicians, like general practice physicians and nurse practitioners and primary care providers, to do what they always do, go through their usual motions, and then they interact with the urologist that says, hey, you should be running this test, which gives us more information faster. And then, in a few months, they start doing that with their patients. So I mean, the rollout of information and advice that goes generally from specialists back to general practitioners takes months, if not years. So that's part of the reason of having this focus group or advisory board in Ottawa with the urologist to say, how do we expedite this? What's our best process to get this information to physicians and change practices quicker? As you know, changing anybody's usual routine takes time, and there's often resistance just to status quo, if nothing else. So that's why we do these presentations, not just to provider groups, but also at conferences across the country. We have been for a couple of years, but still the test has only been available since the fall of 2023. So hopefully through these different processes and the information that comes out of this focus group, we'll be able to do this much faster.
So it's a very slow process, and it's not easy. It's not easy at this point to see whether or not the CUA is actually on board with your approach.
They are. I mean, I mean, CUA is made up of urologists from all across the country, so it isn't a collective voice that says yes or no. But I mean, there's going to be individual variability. But there were about 6 urologists that were involved with the development of this test. And actually, initially, it was thought to be a resource for urologists. And then there was the realization as the validation study, when it was underway, that this makes a lot more sense at the primary care level. So we can figure out who actually needs to see a urologist. So to a forward-thinking urologist, that makes a lot of sense. To a sort of maybe a controlling urologist, they're like, well, no, I want to see all the patients. I want to do all the tests. So you end up with that little, pocket of resistance from people that don't like to change or that kind of see things differently. But to the objective, evidence-based view, the CUA as a general entity supports this as a valid approach and the way that things should change.
Well, and I was just thinking about it, the urologists aren't the only players in this game. There's a lot of radiation oncologists that would want to have some sort of a say in the matter of whether or not this is implemented, right?
Yeah, there's a lot of cooks in the kitchen, so to speak, and getting everybody on the same page. It takes time. Like, changing the way that we treat heart attacks or we treat strokes took decades and studies that showed the same thing over and over and over again before, a cardiologist would say, oh, well, the last 10 studies showed that this should be done. I should change my practice. It's a shame that it takes that time, but, the urologists are no different. So it'll take a few rounds of showing that this is actually the future, using machine learning and using several biomarkers and adjunctive testing strategies and changing the culture, because for a while there, screening for prostate cancer was passe, but now when we can make it safe and effective and efficient and life-saving again, that's changing culture, but we will get there.
This question is going to seem a little bit down in the weeds, but I'm kind of interested to know how you quantify the results of a digital rectal examination. Do doctors follow some sort of a standardized way of describing what they found?
For the sake of this test, it's actually only measured normal or abnormal. So
Ah,
it's not, we're not trying to describe how many nodes are on there or the volume or how squishy it is. It's just a yes or no, normal, abnormal. So if it's small, round, smooth, that's normal. If it's enlarged, there are nodules. Anything that's not small, round, smooth falls into the other category.
Okay, thanks.
if someone in Ontario decided to go through this and they get the results, what do they do with them? Because if they don't have a doctor that's supporting your stuff, what would be the end result?
Well, actually, dozens of men in Ontario already have. And
Okay,
to order the test, you're doing it with the doctor. So some of that getting on board already happened when they ordered the test, because the reason that they signed off on the requisition is they want to see what the results are and take it into account. So some of that is already figured out before the test was ordered. There are other physicians that, you know, may be hesitant and maybe they take a little bit more convincing, or the patient really pushes hard, or that's why we present to groups like you. I mean, men who have had to deal with prostate cancer are much more motivated, much more knowledgeable, and they tend to, you know, say to their doc, no, this makes sense. So slowly we'll get more physicians on board, but by the time the physician has ordered it, the results come back and they're already sort of on board of taking it into account. So that $500, like I say, several men have already paid for it, but also men that have a health spending account at work have had that covered. So that isn't always coming out of their pocket. There are some ways to get it covered, and hopefully the results of this clinical utility study will have OHIP covering it. It has been covered by some employers that way.
okay.
I can't speak to all of them, and hopefully, I mean, the ideal is that OHIP covers it, which is where we're trying to head, you know, and get the right evidence to support that decision. I mean, the only reason that OHIP wasn't covering PSA was because too many men were getting biopsies that don't need it. This test precludes that. By prioritizing high risk cases and keeping low risk cases from getting biopsies unnecessarily, you're fixing the problem. So now it makes sense. Like, it's efficient and actually cost saving to run this test. The OHIP will be saving money that's going to be spent other places, like, you know, on biopsies that aren't needed or complications or something like that. It's getting the right level of government figuring that out, and the budgets to, you know, make sense.
So you're saying you're having a conference in Ottawa this summer. Is that correct?
Yeah, actually, in less than 10 days, July, the CUA conference is the 27th, 28th, and 29th. And on the night of the 28th, we have a focus group with several of the urologists in Ottawa.
I just wanted to ask, you take the blood information and you connect it with age probabilities, I guess, right? We've heard lots of stories where, you know, some people get diagnosed in their 40s, some don't get diagnosed until their 70s or 80s. Is this test able to identify a high-risk person who is maybe in their 40s, where they're kind of considered low risk according to their age?
Absolutely. That's what I was saying about some physicians, you know, might be measuring PSA and free PSA and then taking age into account and sort of like juggling all these factors in their head, which, you know, some people are good at. The machine learning algorithm that has been validated using 3,500 men in 3 different countries, it is consistent and it takes those factors into account itself. So it's doing that all the time to take the age into account and take those different levels of the biomarkers into account, so that you're not, you know, trying to juggle a table and an age-related risk for a man in his 40s versus 70s. The computer does that. Thank you very much.